It's my pleasure to welcome you to this special evening. My name is Rick Page. I'm Dean of the Larner College of Medicine and Chief Medical Affairs Officer here at UVM. It's a pleasure to welcome you to the second course of the third year of mini med school. Now, show of hands, how many of you are juniors? There you go. And we're the freshmen that we're razzing tonight. There we are. Thank you. Welcome. It's never too late to become a mini med graduate. And after that, you become an alum, and you know how deans are with alumni. By day, you heard my title. By evenings, when we have mini med school, I'm privileged to be one of three deans of the mini med school. Noma Anderson, Dean of the College of Nursing and Health Sciences, is one of the other deans, and Steve Leffler, who has multiple jobs these days, but most recently CEO and president of UVM Health, as well as being in charge of UVM Medical Center. Our goal for mini med school is to bring in members of our community to learn more about disease that affects the lives of all of us, as well as giving you an opportunity, an insider's view, if you will, on what it's like to be a physician or a scientist or an educator or an engineer or a physical therapist or whatever the role might be within this amazing university caring for our community. Now, today we've picked a topic that touches all of us, myself included, just in the last few years within my family, and that is cancer. And even more important, we're focusing on rural cancer care. We owe it to our community, to our state, to our region, to address this and to work out ways to improve cancer care. The deck is stacked against you relative to urban areas if you live in a rural community in terms of cancer care, and we're here to change that. Now, we're so fortunate to have a cancer center right here in our own community. And we recognize, as all of you do, one of the attractions to living in this community is we're in beautiful rural Vermont, but we have a world-class medical center, a world-class health system, and a world-class cancer center, as you're going to be hearing more about this. Now, central to the cancer center and everything we do is clinical care, education, and research, as well as service to our community. Today, you're going to be hearing about all of that from a multidisciplinary set of faculty you'll be learning from and learning more about from Dr. Holcomb, our Cancer Center Director, in just a moment. Now, the other thing I need to mention to you is the work that we do, much of what you're hearing about, has been funded by many different ways, but among them, philanthropy. We could not have done what we've done without the support of our community and generous donors. Many of you may have parked over on the other by the Given building and seen the Firestone building. The Firestone building was built thanks in large part to philanthropic donation, and frankly helped put together a package that ended up bringing Dr. Holcomb here in terms of one floor of that Firestone building is dedicated to cancer research. So that's the sort of support that we're so fortunate to have. And if anybody wants to learn more about that, we're happy to share that with you. Now it's my opportunity to introduce one of the other mini deans, if you will, who's a real dean by day, and that's Dr. Noma Anderson. I'm going off script a little bit here, Noma, in that to the pain of many of us, she has announced her retirement at the end of this academic year. I've got to say that she's been an amazing partner as we're the two healthcare deans within the university. She's been an amazing partner to Steve and myself, And let's just give her a warm welcome and acknowledgement for all she's done.
Thank you, Rick. And thank you so much for that very kind introduction. And I'm retiring. I'm Noma Anderson, Dean of the College of Nursing and Health Sciences. Thank you for being here today. And I'm so pleased to have the opportunity to join my colleagues welcoming you to Mini Med School. The College of Nursing and Health Sciences, the Larner College of Medicine, and UVM Medical Center share a strong commitment to interprofessional collaboration, an essential component of healthcare today. Tonight, you will hear from faculty, clinicians, and researchers across disciplines who are working together to advance cancer care in rural communities, and the science that informs it. Throughout the College of Nursing and Health Sciences, we emphasize culturally inclusive health perspectives, compassionate care, and advocacy for all of our programs. We prepare future health professionals to promote well-being in communities across the state and across the country. Our guiding principles are simple. We teach, we heal, we discover. In our college, we prepare the nurses who stand at the bedside of cancer patients, the medical laboratory and radiation scientists who detect disease and track its progression, and the researchers and clinicians who are advancing recovery and redefining survivorship. Thank you very much, and I now want to welcome our third Mini Med School Dean, Steve Leffler.
Thank you, Noma. So you just met two real deans. I am a fake dean, just like you're not really medical students. I am not a real dean, but I'm proud of this role when I'm here for Mini Med School. So thank you very much. So I know you're going to enjoy this evening. It's an amazing presentation, and please be curious and ask lots of questions. There'll be a chance at the end to reach out for questions. So what I really want you to know tonight is that UVM Cancer Center is here for all of us when we need it. When you think about a cancer diagnosis, which unfortunately many of us will get in our lifetime, or someone that we know or love, oftentimes cancer treatment can take a long time. You can be getting chemo over weeks and months. You can be getting radiation therapy. You can be getting surgical care. And if you have to leave your home to get that care, that can be extremely difficult. We know for sure that getting that care close to home when it's available, when it's possible, you can get the best possible treatment, makes a huge difference for you, your recovery, but also for your families. It's not a given that we have a cancer center here in a small town like Burlington, Vermont. We're fortunate to have it, but even more amazing is the world-class people we have here delivering that care. We're so fortunate, and you're going to see just a slice of the amazing things that happen in our community and region for patients that we serve across all of Vermont and upstate New York are able to get cutting-edge therapy here. And if it wasn't here, they'd be traveling to Boston or New York City or Philadelphia. But we can get the care here. We can get results as good, if not better, than those locations. And so we're so fortunate. I know you're going to be impressed with what you hear tonight. And thank you for supporting this amazing care that we can deliver here for all of us and our families when we need it. Thank you.
So now, class, I get to introduce you to your course director, who's going to be the MC for the rest of this evening's programs. Dr. Randy Holcomb is professor of medicine in the Division of Hematology and Oncology. He is associate dean for cancer programs. He is director of the integrated cancer programs of UVM Health. He is the J. Walter Juckett endowed chair for cancer research at the University of Vermont, an endowed position that helps support him in his work. And finally, he is the director of the UVM Cancer Center. He was recruited in 2021. Many of you knew and remember John Brumstead. John Brumstead and I partnered to bring Dr. Holcomb all the way from Hawaii, where he was director of their cancer center, to come here to Vermont. You may not realize it, and I didn't realize that until I started speaking with Randy, that Hawaii and Vermont have a lot in common. Actually, there's a lot of rural population in the Hawaiian Islands. They go out, what is it, 3,000 miles to his. We're a big state, we're not that big. But he was responsible for care beyond the city for patients in a huge geographic area, making him the perfect person to help bring us to the next level here at UVM in representing Vermont and the North Country of New York. Since arriving, he had an agenda for us to meet the level of excellence in clinical care, research, education, and community service that would allow us to be designated by the National Institutes of Health, National Cancer Institute, as a designated cancer center. That's a big deal in that it recognizes excellence and it also brings further support federally for our cancer programs. I'm happy to say that this fall, on this 5-year journey, he will be submitting a, 4,000-page grant? About a 4,000-page grant based on the work he's done, based on the excellence that you're going to hear about, to bring designation as a cancer center federally back to this region that deserves that level of care. So with that introduction, please join me in welcoming your MC, your course director for the evening, Dr. Randy Holcomb.
Thanks, Rick. That was way too nice an introduction, but I appreciate it. Welcome to you all. I'm so glad to see all of you coming out here tonight. As you heard, I'm Randy Holcomb. I have a bunch of different titles, but today I'm just MC to introduce some of my great colleagues. I'm so pleased that you're going to hear from them tonight because you're going to learn a little bit about the breadth of excellence that we have at the University of Vermont Cancer Center. Tonight, we're going to focus on rurality and serving our rural communities. Why is that? Well, if the Cancer Center is going to serve its community, and we're here in Vermont and also serving Northern New York, we better do a good job in serving our rural cancer patients as well. We do a pretty good job, but can we do better? And the answer is yes. And you're going to hear about some of the ways in which we're working to do that even better this evening. You'll hear those examples. I want you to pay attention throughout the whole evening. There'll be a quiz at the end. There'll be a small 4,000-page booklet that you'll be able to leaf through, which you'll be able to answer your quiz questions. So I'm going to tell you today a little bit about rural cancer care reimagined. I'm going to give an introduction before I bring up my colleagues here, just because I took 7 minutes of time, and so I might as well use it. So what is the issue? Well, we serve a rural community. Over 70% of people in Vermont and Northern New York, when taken together, live in a rural community. And over 50% live in a rugged rural community. That basically means really rural and really hard to get places. And so why is this important that we focus on rurality? Well, these graphs you can see starting from the left to the right are going down. That means that cancer mortality, the death rate from cancer, has been falling over the last several decades. But what you'll also notice is that the green line, which is an urban area, is falling faster than the blue line, the rural area. there are disparities here between cancer patients in rural areas compared to cancer patients in metropolitan areas. Cancer patients in rural areas are 20% more likely to die from cancer. And part of our mission is to address that disparity. So how do we do that? Well, we do that by reaching out across Vermont and northern New York. And we like to think of this as a rural cancer care revolution, because we're going to do things that other places have not been able to do to try to reduce that gap, that disparity between rural and urban. So before I get to some of the ways that we are doing that, let me tell you a little bit about the cancer burden in Vermont and northern New York. For men, prostate and lung cancer are the most common cancers, and for women, breast and lung cancer. One of the things you'll notice is that melanoma happens to be on both of these pie graphs. And melanoma is a big problem, especially in Vermont. Vermont has the third highest rate of melanoma among all the states in the United States. We don't exactly know why that is, but we're doing a lot of research to try to figure out what the causes of that are. Because our incidence in Vermont is actually much higher than the incidence in northern New York, though our exposures environmentally and our populations are really quite similar. We also have to think about what happens in rural communities related to screening for cancer. And when we think about screening and prevention for cancer, we do a pretty good job in our rural communities related to breast cancer screening. But as you'll see from the graphs on the left, the orange graph is a lot shorter than the blue for lung cancer screening and colorectal cancer screening. And what that means is that we have a lot of progress to make to get lung cancer screening and colon cancer screening more frequently done by our individuals in rural communities. So some of the things that we do to try to think about screening and prevention, we have a big sun safety campaign because of the high rate of melanoma. You may have seen our buses with our bus wraps driving around town. We have sunscreen dispensers. This is at the Lake Monsters field. And we also have a mobile van. You're going to see another picture of that in a minute, where we can do skin checks, partnering with our UVM Health dermatology colleagues. We also focus on lung cancer screening. Lung cancer screening, and you'll hear a talk from Dr. Brazino today about a novel approach to lung cancer screening. But right now, lung cancer screening is very difficult for rural residents. So we have to remind people to do lung cancer screening. We have billboards about that. And on the graph, on the map on the right, you'll see all of these little yellow, orange circles. Those are all Stewart shops around Vermont and northern New York, where we have posters to remind people about lung cancer screening. They're in the Stewart shops because people are buying their cigarettes there. And we'd like them not to buy their cigarettes there. And if they are going to buy their cigarettes, to remember that they should undergo lung cancer screening. We have lots of outreach programs. I've already mentioned our skin checks that we do in the van, and these are some pictures of our outreach, what we call our outreach and education van. We also have programs to distribute something called a FIT test. That's a test for colorectal cancer screening, which detects blood in the stool. We also have some targeted lung and breast cancer screening programs partnering with UVM Health and Southwestern Vermont Medical Center for HPV vaccinations. And we also use this van to do cancer education outreach, especially to impressionable individuals in middle school and high school, because that's where they need to learn about cancer prevention and screening. So we use our outreach and education van. That's what we're doing now. That's on the left side of this slide. On the right side is what we're going to be doing in the future. And we're starting the work to set the seeds for this right now, to develop a peer-to-peer telehealth network to support primary care physicians across Vermont and northern New York, and provide them with the backup of oncology providers and oncology advanced practice providers, so that cancer patients in rural areas can get some of their care closer to home and not have to travel to Burlington for all of their care. We call that the Vermont Cancer Model, and you'll hear more about that as time goes on because we're just implementing it now. Tonight, you're going to hear from this collection of mini medical school faculty. These are great colleagues. They're doing wonderful work. I'm going to come up in between each one of them and introduce them. Right now, I'm going to introduce Dr. Nancy Gell, who is going to talk to you about how an old idea can be refashioned into a new idea that's going to help cancer people and people who've had cancer, who are cancer survivors, moving into the future. So, Dr. Gell.
Thank you. Thank you so much for allowing me to talk about my favorite topic. And let's start with a little bit of a foundation and make sure we understand why it's important to talk about physical activity and cancer and what the benefits are related to physical activity. So I've provided an abbreviated list here for you. They didn't give me the whole evening, so I can't talk to you about this all night, although I'd like to. But I want to focus in on a few key outcomes from physical activity that relate to general health and cancer. So we know that physical activity and exercise are associated with maintained or improved physical function, which is our ability to move and do the things we want to be able to do, especially in the context of aging. And related to cancer, physical activity is associated with improved survival rates. And it's also associated, it's been shown to reduce the risk of cancer coming back or recurring in certain cancers. And notably, that's in the common ones of breast, colorectal, and prostate. So how are we doing in terms of connecting people who have had cancer treatment with doing physical activity? So in my lab and some other labs in the country, we use what we call nationally representative data. This is data collected across the country through surveys and interviews with thousands of people. And we ask them questions, or they ask them questions, and we get to analyze the data. And unfortunately, we have some work to do. We've learned that less than 20% of cancer survivors are meeting the recommendations for aerobic and muscle strengthening activity. So those recommendations are 30 minutes most days of the week of moderate intensity activity and muscle strengthening 2 or more times per week. And it's a little worse in our rural communities where less than 10% of cancer survivors are meeting those recommendations. If we break it up and we go with the approach of, well, something's better than nothing, and maybe people are doing something or at least one type of exercise, we still see that less than a third of adults with cancer history participate in that 2 or more days a week of strength exercise, and 37% are doing the aerobic activity. As I said, we have some work to do. What are the options for people who've gone through cancer treatment in terms of connecting with exercise options? So I'll start by saying that exercise-based oncology rehab is the gold standard. This is modeled on the cardiac rehabilitation model, if you're familiar with that. And it involves having exercise cancer specialists provide supervised exercise in person in a facility geared towards this. But this is still a newer concept, and so many communities in the country don't have access to this. So what happens when people don't have access to that gold standard? Well, there's videos and DVDs and mobile apps for people who feel like they know what they're doing and are motivated to do it on their own. People can go to a local gym, but we know that immunosuppression is sometimes a barrier for that one. There's also personal trainers, but we know that that can be cost prohibitive for many people. But I also want to acknowledge something. I want to see if anyone in this room remembers this guy, a few of you. Now, we have some younger people who may not know Jack. Does anyone remember Jane? Yeah. So I want to acknowledge, because, they did remotely delivered exercise, right? And they had a huge impact. I mean, they really connected thousands, probably millions of people with exercise. And I want to acknowledge that. But I also want to acknowledge the limitation that it was a one-way delivery, right? So we could see them, but they couldn't see us. I can vouch that I did watch them. I don't know if I did them. So let's talk about what I'm talking about with remotely delivered exercise in the cancer space. These are scheduled, live, online classes, and they include all those important types of exercise: aerobic, strength, balance, and flexibility. They use weights and household objects for that resistance training. The trainers have the ability to modify the exercise depending on what participants need and what they're able to do, including teaching an exercise in a seated position and the same one in a standing position. And the other thing that's minor but key is that the instructor is looking at the class in that gallery mode, so they can see all the participants, and that's how they know how to modify and how to tailor their instruction. The participants see the instructor in that spotlight mode, so they're actually getting a very personal delivery of the exercise program. So what are some of the common barriers we're overcoming with this approach? Well, people live in places, especially in rural communities, where they don't have access to parks or sidewalks for walking. We're providing access. We're overcoming that barrier of transportation. We were really interested to learn from our own work that caregivers in particular were appreciative of this, because they said, I can't leave my loved one to go and exercise. And so they were forgoing their own care, but this allowed them to stay home, still take care of their person, and also get the exercise that's so beneficial. This is helpful in the barrier of immunosuppression, and people get that professional guidance when they have a fear of injury or pain. What does the research show to date? So the pilot feasibility studies are very promising, and I'll talk a little bit about more of our own results from the study we did here. There's been 2 large trials in Sweden and Canada, and they have shown significant improvements in physical function, cardiorespiratory fitness, strength, and balance. So those outcomes are exciting. We did a study before even starting, because I would ask you, what do you think everybody was concerned about? Technology. Oh, the people can't do technology. They'll never be able to. Well, we talked to older adults, and we learned that it's not the barrier when it's in support of something that is important to them and when they have the right kind of support. And we also did a study where we said, well, are people working as hard as they do when they're in their house as they do when they're in a community class? So we measured their heart rate and measured the intensity, and we learned that they were able to achieve that moderate to vigorous intensity while doing the remotely delivered exercise. We also had a chance to talk to people because we wanted feedback. We said, we're trying this out and we want to know how can we improve this? And mostly it was pretty positive feedback, which was great to hear. And I think the quotes are the most powerful part of it. So I just want to share those with you. I didn't really expect it to be so helpful and so useful. I kind of figured, it's online, you're not going to get much out of it, but I did. The convenience of Zoom for this, it's wonderful. It's so much more efficient than having to run off somewhere and using half a day for 45 minutes of exercise. And I should note, this is from a study of older rural cancer survivors. So they really did have to travel far if they wanted to get to exercise anywhere else. Because we had a cohort, I was committed, and I said I'm going to show up every day. So let's just review what we've learned from researching this type of exercise so far. We had a lot of concerns around safety and is this feasible and will people accept it? And those concerns were mostly unfounded. We learned that older adults can learn new technology that aligns with their goals and with the right kind of support. We learned that attendance is on par or even better than in-person programs, mostly probably related to overcoming some of those barriers like transportation and convenience. We're seeing significant improvements in symptom severity and physical function and fitness, that participants value the accountability, the reinforcing benefits, and the convenience. The one thing that we've seen is that we don't have as much of the social support that is so vital in the in-person exercise program, so we still have work to do in that area. Where are we going with all this? Well, we have a lot still to study. We need to look at long-term participation. Is this sustainable? How do we get people connected to these programs, right? Can we establish some referral pathways? Can we try to address the loneliness epidemic and social engagement through this platform? And then finally, what I failed to share with you was that most of the studies to date have recruited women. And so we need to learn more about reaching underserved communities and to see if we can recruit men to participate in these. And I'm excited because in our next study, this is exactly what we're studying, to see if we can recruit men with prostate cancer for this type of exercise. I want you to know that we have that gold standard exercise-based oncology rehab here at the University of Vermont Cancer Center and UVM Health, and it's called Steps to Wellness. And remarkably, they offer it in person, but they also have expanded to delivering it remotely so that we can reach beyond Chittenden County borders. And if anyone in this room is intrigued and wants to try remotely delivered exercise for yourselves, UVM Health offers a free community fitness option called Made to Move. And that's remotely delivered. And feel free to ask me about that because I'd love to connect you. I want to acknowledge my great team, and I want to acknowledge that our work was funded by a UVM Cancer Center pilot grant. We couldn't have done the work without that. And this has led now to funding from the Centers for Disease Control to continue this work, which I'm really excited about. Thank you so much.
Well, that was fantastic, Nancy. Thank you. So Nancy mentioned that some of this work was funded by a pilot grant. The Cancer Center doesn't grow that money. That money actually comes from philanthropy. So it came from donors, and we were able to provide that as a pilot grant. All of that work that I talked about in the beginning about our outreach van, our Vermont model of cancer care, all of that is also funded through philanthropy. So this is a way that we can jumpstart programs. We can get the preliminary data that we need so that we can obtain extramural funding from the National Institutes of Health and other foundations. So Nancy, great job. I have the privilege now to introduce Emily Hallgren. She's one of our newer faculty members here at the Cancer Center. And she's had a long-term focus on rural communities, first in Arkansas and now here. And she's going to talk to us about financial toxicity. You may not know what that is, but you will soon, and you will pass the quiz at the end of this session tonight. She's going to tell you why this is such a big problem for cancer patients, particularly cancer patients in our rural communities. Emily.
Oh, wait, I have a lapel mic. Thank you, Dr. Holcomb, and thank you, students, for all being here this evening. When someone is diagnosed with cancer, there are questions and distress that we often see. These are existential, fear, distressing conversations about preserving quality of life versus maximizing survival chances, right? But there are also questions and distress that we may not see. These might be, how will I afford the medical bills? Will I have to leave work, perhaps permanently? And how will I even pay for the gas and lodging to get here for these treatments? And these distressing questions in my field we actually call financial toxicity. So what is financial toxicity? This refers to the financial hardship and distress that are common side effects of cancer treatment. And this term toxicity is really intentional. It's meant to highlight how similar to cancer therapies such as chemotherapy that are designed to attack and kill cancer cells but may have toxic side effects on our patients' bodies, similarly, cancer treatments are saving lives every day, yet there could be toxic side effects on the financial security and quality of life of patients and their families. And this has been recognized as a growing public health concern. Financial toxicity is reported by at least half of all cancer patients and caregivers, and it is the #1 patient concern discussed with oncology social workers and patient navigators. That is true here at UVM with our social workers and navigators, as well as across the world of cancer care more broadly. And so this concept of financial toxicity has been around for more than a decade now. We've been thinking about this kind of toxic effect of the financial issues. And we've really come to see it as a multidimensional problem with overlapping domains. So we have the material conditions. We also have the psychological response to that, as well as coping behaviors. So I don't have too much time to dig into this, but what I'd really like you to take away from this is that it's not just that bill or that prescription that insurance wouldn't cover. It can really affect our patient's ability to stick to their cancer treatment. And as a cancer center, that is very concerning for us, right? Because we want to partner with our patients to create treatment plans that they can stick to. So, what does financial toxicity look like in a rural context? This has been a primary focus of my work for the past several years. And I've really tried to dig in through different methods, quantitative, qualitative, to really understand what is the experience of financial toxicity for our rural community members, and really thinking about what are those rural challenges, but also rural strengths, right, that shape the experience of financial toxicity for our rural residents. So let's dig in just a little bit. So let's just get the objective facts out there. Financial toxicity is indeed worse in our rural communities. Rural patients report significantly worse financial toxicity compared to urban and suburban patients. We see this borne out in the data over and over again. But what are some of those rural challenges, right? Why is it that financial toxicity is worse in our rural communities? So let's take a look at that. So myself, along with other colleagues and researchers in this field, have identified several of these challenges. The one on your left may be one that you may have already been thinking of, right? Longer travel distances to quality cancer care, transportation, long distances, lodging. These things can really add up and can really be barriers for our rural community members. Lower household income and fewer assets. This means that many rural families are starting with less when they embark on what may be a very expensive cancer journey. Higher rates of disability, unemployment, and limited job markets. So perhaps someone has gone through treatment, they're a cancer survivor, but they have some new physical or mobility limitations. They would like to stay working, right? But they can't find a job that meets these new limitations and they fall out of the workforce. I've seen that happen in the work I've done. As well as less access to financial assistance resources. And this can also look like less awareness too. Our rural residents might just not be plugged into those resources that actually are out there. But this is not the whole story. When it comes to rural communities, we often hear only about the disparities, right? All the doom and gloom. But myself and others have also identified some rural strengths that shape the experience of financial toxicity. So one of these is a high degree of resilience. Again, I can't go into too much depth here, but how this can look is perhaps somebody has a lot of objective financial hardship, right? Maybe they've even declared bankruptcy due to medical debt. However, their financial distress is not actually as severe as we think what might be. Another rural strength is a very high degree of community participation and volunteerism. So for those rural patients and families that are really socially embedded, that have strong social ties, this can be a huge source of support. Fundraisers, meal trains, all of these types of supportive help. We also see more informal support in caregiving. Now, this makes sense, right? There are less paid caregiving services in rural places, and people have less money to pay for those types of services. However, while this is a rural strength, it can have a shadow side as well, right? Because this is putting a lot of strain and burden on our rural caregivers. So taking a little bit of a closer look at that, indeed we see that rural patients rely more on informal caregivers. Again, it's wonderful that we see all of this informal support, but it can really take its toll. And from the data, we know that rural caregivers report significant financial, travel, and time burdens more than urban caregivers do. They face more challenges accessing resources for patients and for themselves. They take time off work or accept lower paid employment to accommodate caregiving. And again, coming back to those limited rural job markets, if a caregiver steps out of the workforce, they may struggle to find that foothold back in. So now that I've talked a little bit about the challenges and strengths in rural communities that shape this experience of financial toxicity, I would like to bring in patient and caregiver voices just for a moment. So one caregiver that I interviewed told me, cancer takes such a financial toll. We have good insurance, but we spend our money going to the doctor and driving to the cancer centers. The drive and hotels can add up. Cancer can take over your life. Maybe someone in your life has had a similar experience. And this next quote is actually from a survivor in Arkansas, where I was doing research previous to coming here. And this person shared with me, if I'd had vouchers for gas or food or lodging, I wouldn't have had to put so much support on my family. That would have helped and took some of the stress off of me and them. And so I do just want to take a moment to note that here at the UVM Cancer Center, thanks to the wonderful, generous philanthropy that we receive, we actually do have a lot of these types of resources. So gas cards, ferry passes, grocery gift cards, and nutrition support. We partner with the American Cancer Society to provide lodging through Hope Lodge. So I just want to acknowledge that a lot of those resources are available for our patients, rural or not rural, as needed. But in the case of this rural Arkansas survivor, they obviously were not plugged into those types of resources. Okay, so I've tried to paint a picture of financial toxicity and the hardship that it causes in rural communities, right? We know this is a big problem. But luckily, as a researcher, we tend to look for solutions, things that we know have worked somewhere else, right, that might work for us too, and we call those interventions. So one intervention that I'm really passionate about is financial navigation. And this is an evidence-based intervention that can effectively reduce oncology patients' financial toxicity. So at the heart of this is a human being called a financial navigator who is specially trained to provide personalized support to patients to reduce the material and psychosocial burdens of cancer. So financial navigation can involve a whole range of support. It often takes on a case management style, so a patient and their family are helped over time, perhaps with support finding financial assistance programs, breaking down the barriers to make sure they can actually access those programs, health insurance guidance and optimization, guidance on employment and disability, as well as ongoing follow-up support as needs change. And so again, I'm very passionate about these programs, but as I've been researching them, what I found is that existing financial navigation programs have some limitations. They tend to focus on the patient only, so they're not thinking about cancer as a shared experience, right? They're often leaving out the caregiver, who, as we've seen, can have a great deal of financial distress. And they've been mostly developed in urban settings, right? So they're really not tailored to the needs of rural people. But luckily, here at UVM, we are doing something about that. So a primary focus of my work currently is developing a financial navigation program that will actually meet the needs of our rural patients and their caregivers. So as Dr. Holcomb mentioned, we serve a very rural catchment area. We also have an older aging population. And I think this third piece is really striking. Here in Vermont, we have the largest share of older adults living in rural areas. So taking all this together, the work that I am currently doing is to adapt an existing financial navigation program called LIFT, Lessening the Impact of Financial Toxicity, specifically for rural, older patients and their caregivers. So bringing in that cancer as a shared experience idea. And we're calling this LIFT Care, which is LIFT for patients and caregivers in rural environments. So in my last minute or so, I'll just give you a little glimpse of that work. And this is currently underway, funded by a cancer center pilot study, again, which is funded by the generous philanthropy that the Cancer Center receives. And so we're currently collecting data. So that means doing interviews with rural older patients and caregivers, conducting focus groups with oncology social workers, patient navigators who are really on the front lines of dealing with these issues for patients and their families. I just held a wonderful focus group today that I'd love to chat about. And then the second piece is where this work really becomes very community engaged. So we're also putting together a stakeholder advisory board, and this will include people who have that real lived experience. So rural cancer survivors and caregivers, as well as some clinicians, to collaboratively design this financial navigation program. So we'll really learn from those experts, how do we make this work for our rural, older residents? And a lot of those members have already been recruited, but this is actually a place where you could come in as well. If you know of somebody who's been affected by cancer, who lives in our rural catchment area, feel free to reach out to me. Maybe they'd be a good fit for this project. And then finally, we'll test it, right? So we'll bring this program to some patient caregiver pairs and see, is it working? Is it reducing hardship? Is it reducing distress? And is it feasible, right? So thinking back to Dr. Gell's presentation, maybe we need to remotely deliver a program like this, or maybe people really want to come in person to have this kind of support, right, with the financial challenges of cancer. So that's the next step that I'm currently working on. And so just to close, I really do believe this could be a paradigm shift. We could expand this program to meet the needs of other rural older patients and caregivers across the US, as well as support the integration of financial navigation into quality cancer care for rural and hard to reach populations. And that is the end of the lesson for today. Thank you.
Thanks, Emily. That was great. So next time when you're out with friends, you're in a group, I expect that the term financial toxicity will come up in casual conversation because people will be like, "Wow, aren't you smart? I never heard of that before." Well, I get to introduce now Michael Brazino. He's an engineer, but he's working on a cancer problem. And you already heard that we don't do a great job for lung cancer screening, especially in patients in our rural areas. So Michael's not thinking of what can we do to make it a little bit easier for patients to do the traditional lung cancer screening. What he's doing is creating a whole new way to do lung cancer screening. And so listen carefully because your mind's going to be blown by the end of this talk. Michael.
All right. Hi, everybody. Thanks, Randy, for that excellent introduction. So as Randy said, I'm going to be talking about a completely novel way to do lung cancer screening that we're developing in my lab in the College of Engineering and Mathematical Sciences. So first off, why screen for lung cancer in the first place? We've talked a little bit about that already, but just to put it numbers to it, lung cancer is the #1 cause of cancer-related death in both Vermont and northern New York. And that's a real shame because it's fairly much easier to treat when it's detected early. However, the only current method for detecting lung cancer in asymptomatic individuals is with low-dose CT scans. What that involves is people going to low-dose CT centers where they get into a machine that looks like this on the right. Oh, good, this works. Into a large machine that you see on the right, and that takes images of their lungs, and then a panel of experts pore over those images and find evidence of masses that might be an early tumor. That whole process isn't particularly sensitive or specific, and because of that, it's only recommended for individuals who are at high risk of developing lung cancer, specifically those who are above a certain age and have a history of heavy smoking use. This is a 30-pack-a-day history. Because it requires travel to these specialized centers, it can be particularly burdensome for rural patients who have to travel hours at a time just to undergo one scan. And because of that, it has very low uptake. It's hovering, as discussed earlier, around 30% in urban patients and below 20% for rural patients. And so because of the failures of LDCT so far, we're looking for a new way to screen for lung cancer in a completely different way. And the way that my lab is trying to do that is with genetically engineered bacteria. Now that sounds very strange. And so let me talk to you a little bit about it and give you an idea of how we're thinking this will work. How we envision this happening is that individuals who are at risk of developing lung cancer would inhale with a nebulizer or some type of inhaler device genetically engineered bacteria into their lungs. Now, those bacteria wouldn't colonize or grow very much, but when they're down there, if there's a tumor present, they would detect molecules coming off of the tumor site and in turn secrete other molecules into that patient's urine that they could detect at home. Now, this has the advantage that because the bacteria can be administered at home and the urine can be tested at home, everything wouldn't require travel, and we'd be much less burdensome for rural patients in particular. So to start trying to see how any of this works, we had to choose a bacteria. We decided to start with Lactoplantibacillus plantarum, WCFS1, which I won't say the name of again, and just refer to as the bacteria. This was originally isolated from a healthy child's saliva, and it's been marketed as a probiotic in both Europe and the United States for decades, which indicates that it has a very nice safety profile for consumption in humans. There's also been a number of methods that have been developed for simple genetic modification of this bacteria, meaning that we can stick genes or pieces of DNA into its genome in specific sites fairly easily. The first thing we wanted to do, now that we had chosen our bacteria to use, is see what would happen when it was administered to the lungs. To do this, we started with mice because we didn't want to do it in people first. And to better track where the bacteria went inside the mouse's bodies, we made it bioluminescent by inserting a gene for luciferase. This makes the bacteria glow, much like a firefly or many marine organisms, and that allows us to detect where it goes in the body with a very sensitive camera. So we administer our bioluminescent bacteria to the mice, and then we image them sequentially. So first we take an image of the mouse with the lights on with a normal camera, and that's shown in black and white. And then we turn off the lights and take a very sensitive, or take an image with a very sensitive camera, which shows the bioluminescence of the bacteria and where they are inside the body, and that's shown in color. As you can see, immediately after we give the bacteria, we see strong luminescence in the lungs. So the bacteria are down there, and they remain there for 7 hours afterwards while slowly being cleared by the mouse's immune system. 2 days later, we don't see any signs of bacterial colonization or travel to other organs. And so this is exactly the type of behavior that we'd want from some type of probe that goes into the lungs, stays there long enough to detect something, and then gets cleared without issue. Now that we had a way of getting bacteria down there, we wanted to see, can they send a signal into the urine while they're still in the lungs? To do that, we engineered a new strain of bacteria that constantly secreted another molecule called nanoluciferase, or NLUC. We administered this bacteria at several different doses to mice lungs, either at a high dose, a middle dose, or a low dose. Sorry, that's very fuzzy for some reason. And then we collected the mouse's urine for several hours after we administered bacteria to their lungs. If you're curious about how you get mice to pee on command, if you pick them up, they generally like to pee on you. So it's not as hard as it may seem. But excitingly, when we took the mouse's urine and measured the amount of NLUC that was in each dose, when we administered a large amount of our bacteria, we saw higher concentrations of NLUC in their urine. And even when we diluted the bacteria to hundreds of times lower, we still saw nanoluciferase in their urine. So it's a very sensitive output from this system. We wanted to see next, can the bacteria actually sense something when they're in the lungs? Are they just going down there and dying and releasing NLUC, and that's why we're seeing it in the urine, or can they actually do something useful? To test this, we made, again, another strain. And in this strain of bacteria, the bacteria secrete nanoluciferase only when they detect a specific sugar molecule called xylose. Now, xylose can't be consumed, can't be eaten, but it activates the secreted nanoluciferase inside the bacteria. We then took our bacteria and administered them to mice with xylose or without xylose, and again collected urine and measured nanoluciferase. In the mice that had both the bacteria and the nanoluciferase, and the xylose administered to them, we saw significantly higher nanoluciferase activity in their urine, indicating that the bacteria can indeed sense something when they're down in the mouse's lungs. So now that we had a sugar-sensing bacteria that could sense sugar in mouse's lungs and secrete something that we could detect in urine, the next thing we needed to do is just detect lung cancer with it. No big deal. So this turns out to be very difficult. There's no good currently developed methods for bacteria to sense molecules that are emanating from a lung tumor, at least none that we could adapt easily. And so in order to show that this can work as a proof of concept, we've cheated a little bit. Specifically, we've taken a lung cancer cell line from mice, and we've tweaked it a little bit so that it constantly pumps out a small peptide that the bacteria can detect. So here, the bacteria, rather than detecting sugar, detect this peptide and in turn secrete nanoluciferase. What that means is that when we incubate the bacteria with increasing numbers of these lung cancer cells, we get increasing amounts of nanoluciferase secreted by the bacteria, so they can detect the quantity of lung cancer cells that are in their surroundings. When we then try this in vivo, or in the mouse's lungs, we take our tumor cells that are secreting peptides, we administer them to the mice, and then they grow as tumors inside the mouse's lungs. Then we administer bacteria to those same mice, and again collect urine and measure nanoluciferase. When we take the urine and measure the amount of nanoluciferase in it, the bacteria that have tumors in their lungs, shown as the black dots, have increased concentrations of nanoluciferase in their urine compared to mice that were administered bacteria but didn't have tumors in their lungs. So these, as a proof of concept anyway, these bacteria can detect an admittedly fake tumor in mouse lungs and report on it in a simple urine test. So the focus of my work here in the College of Engineering, funded by the UVM Cancer Center, is to translate this preliminary work in mice so that it can be used in the clinic and actually help people at risk of lung cancer. To do that, we're focusing on, one, making a delivery system, a nebulizer or an inhaler type device that could be used by people at home to administer genetically engineered bacteria. We're working on new ways for these bacteria to sense real tumor markers, so things that actually come from a human lung tumor. And we're also figuring out ways for the bacteria to secrete something that could be tested for easily in somebody's urine. And I don't have time to talk about all of our work on this, but I can talk to you a little bit about the last two things there. So how are we going to detect a real human lung tumor, not the fake one that we've put in mice? Well, one way that we think we're going to be able to do this is by detecting a molecule called MMP13. MMP13 is a protein that cuts other proteins, so it kind of can look like a scissors or a little Pac-Man shown there. And we think that we might be able to, MMP13 is also overexpressed by a lot of lung tumors. So in humans, you see MMP13 surrounding a tumor frequently. And we think we might be able to detect it with our engineered bacteria by adding what my graduate student calls another player to the mix, this probe protein. This probe protein, when it's surrounded by MMP13, gets cleaved and releases the same peptide that we'd been detecting earlier in the mouse work. And so in that way, when we add our probe protein and engineered bacteria with increasing concentrations of MMP13, we see increasing concentrations of nanoluciferase being secreted by the bacteria. So we have, at least here, a way for our bacteria to sense a real marker of lung tumors in people. But how are we going to get a signal out that people could detect at home with a urine test? For that, our kind of admittedly crazy idea is to just use a simple pregnancy test. Now, pregnancy tests detect a molecule called HCG beta and are actually ripe for repurposing for lung cancer detection because many of the people who are at risk of developing lung cancer are not at all at risk of being pregnant. They are primarily older and they are primarily male. So we have a chance here to repurpose a common everyday urine test for a new and important purpose. The way that we think this could work is by having our bacteria secrete out a version of HCG beta, which is what's detected in a pregnancy test, that's non-bioactive, meaning that it can be detected with the urine pregnancy test, but it doesn't have any of the normal biological activity that is involved in the early stages of pregnancy. To see if any of this would work, we put the gene for HCG beta into the bacterial genome so that it would be secreted constantly. And then we took media from the bacteria and put them on a Walgreens, or I think this is Amazon, pregnancy test. And sure enough, the bacteria are pregnant. So by the way, PSA, if you get a line like that, that is pregnancy. So, just in case you were wondering. So with this, we have a way of detecting real human lung tumor markers and also a way of getting a real signal out that we could detect in urine. So this work is being pursued in my lab in the College of Engineering and Mathematical Sciences, and it's funded by the University of Vermont Cancer Center. We're a new and growing lab. We've called ourselves the Bacterial Biosensors Lab. Yeah, we're excited to start all this work. Thanks.
Thanks, Michael. The original bacteria that he named and didn't mention again, that will be on your quiz. So I hope that you wrote that down. Now I have the privilege of introducing Dr. Alyssa Thomas, and she's going to, let me put that next slide there. She's going to talk to you about a rural network for brain cancer care. And I think of this as we've been talking about how we can intervene to reduce the disparities between rural cancer patients and urban cancer patients. I think about this as the success story, the work that she has done to reduce that gap and to reduce that disparity. And really privileged to have her talk to you tonight. Alyssa.
Hi. Okay, everybody's awake? Thank you so much. So thank you for this opportunity to talk to you about building a brain tumor network for our rural patients here in Vermont. I'm a neurologist specializing in neuro-oncology, so I care for patients with brain tumors. And the field I work in sits at the intersection of neurology and oncology, which are really two areas with distinct challenges for rural patients. As you heard earlier this evening from Dr. Holcomb, patients with cancer have a higher mortality than urban patients by nearly 20%. And as illustrated in this graph, the green line shows that mortality rates are decreasing for urban patients, but are outpacing the improvements that we're seeing for rural patients. And so these disparities have actually increased over time. In neurology, access to care is highly concentrated in urban areas in the country. And so you can see in this map, there are vast neurology deserts, which largely represent the rural parts of our country. This access gap creates lower utilization of specialists, worse outcome for neurologic diseases, and high travel barriers for patients who are trying to get to specialists. And then these geographic barriers are compounded by complexities of social determinants of health in rural areas, as you heard about from Dr. Halgreen. Within my field of neuro-oncology, as of 2020, 100% of neuro-oncologists practiced in urban institutions. And the vast majority of those, as shown here in the yellow, practiced in metropolitan areas of greater than 1 million people. Only 4% of neuro-oncologists practiced in cities the size of Burlington, between 25,000 and 250,000 people. And 12 states in the country have 0 neuro-oncologists. So we're really fortunate to have 2 of us here now and soon to be 3. For patients with brain tumors, especially cancers like glioblastoma, access to clinical trials is critically important since the standard of care treatments are not cures. In this study we conducted, we found that 95% of clinical trials for glioblastoma were offered exclusively in urban centers, and only 5% of all trials are available to rural patients. So when I came to Vermont about a decade ago with a goal of building a brain tumor program, we looked at this rural catchment area and collaborated with the American Brain Tumor Association and multiple other brain tumor centers across the country to develop a set of guiding principles for what are the core functions needed for a brain tumor program. And this is really centered on multidisciplinary care, access to clinical trials, and access to specialized diagnostic and support services. Glioblastoma is the primary disease that I treat, and so this was our initial focus. Glioblastoma is the most common brain cancer. About 40 to 50 patients in Vermont are diagnosed with this each year. In this MRI scan, you can see the large white area. That's the cancer. And these are tumors that originate from cells within the brain and invade and grow within the brain. Patients with glioblastoma generally present acutely with new neurologic symptoms, so things like headaches, seizures, or stroke-like symptoms. Imaging reveals the tumor, and then all patients need neurosurgery to get a diagnosis, either through biopsy or a surgical resection. That's followed by treatment, which includes radiation and chemotherapy, and often access to a clinical trial. Patients then have regular follow-up with a neuro-oncologist. There are some unique things about glioblastoma that may make it possible to decrease some of the rural health disparities. And this includes the acuity of symptoms that usually brings patients to medical attention quickly, the standardized diagnosis and treatment, and then the need for a touch point in a neurosurgical center. And so we've worked throughout our health network here to have a pathway so that all patients who present to community hospitals around our region come into the University of Vermont for their initial diagnosis and workup. Once patients are here, they have access to our entire multidisciplinary team. We've worked to build this over time with physician specialists spanning surgery, oncology, imaging, and palliative care, and then layering that with health professionals across nursing, rehabilitation services, and home health services. We've also worked to grow our research portfolio. Last year, our neuro-oncology group had 12 clinical trials available for patients with various kinds of brain tumors, and most of these were supported by philanthropy. We had 41 patients participate in clinical trials for brain tumors in 2025. I had a very talented medical student in the class of 2025 analyze some of our data and found that within the UVN catchment area, we had equal survival between our patients in our rural areas and in our urban areas, and their survival outpaced the national average for both urban and rural patients. Nationally, we see that rural patients with glioblastoma live about 2 months less than urban patients. But if patients can be treated in a specialized center and reach a brain tumor program, survival equals out. And so this model that we have here can really be a model for rural care access nationally. As we've worked through glioblastoma, we've started to treat more and more patients with other kinds of brain tumors. And so I'd like to shift some to our efforts now for patients with brain metastases. Brain metastases are roughly 10 times more common than primary brain tumors. And these are cancers that have spread from other parts of the body into the brain. Patients with brain metastases may have one large brain tumor, or they can have a whole number of brain tumors, as shown by all of these white dots here. There's much less data available about survival outcomes or quality benchmarks for patients with brain metastases compared to primary brain tumors. Another medical student who's now a rising 4th year here looked at some of our data, and when we first dug into this work, we found that we too have a disparity in care for patients with brain metastases, with our rural patients not living as long as our urban patients. But we didn't even have survival benchmarks to go on. So when we started this work, the data that we had was from the 1980s and 1990s, showing really poor survival in the range of 2 to 7 months. We looked at our program and combined data with the University of Virginia and Medical College of Wisconsin and found that with modern treatments, patients with brain metastases who are highly functioning can live well over 2 years with their brain tumors. Another challenge for delivering care for patients with brain metastases is that their care pathway is not straightforward. So diagnosis can come at various times early in the course of the disease or much later. Tumors are discovered in different ways, sometimes by brain biopsy, sometimes by imaging, and the treatment is highly variable depending on the underlying tumor type and the size and number of brain tumors. So when we decided to dig into how can we start to streamline care for these patients, we started at one of their earliest touch points. Roughly 40% of patients in our area are diagnosed with a brain tumor on presentation to the emergency room. We had 2 residents and a medical student work on this project, and they found that patients who came to the emergency room with symptoms of a brain tumor spent an average of 7 hours in the ED, and a quarter of them spent more than 11 hours in the emergency department. We looked at the reasons why and found that things like the number of imaging tests and the number of consults called really contributed to this. And so we developed a care pathway that we've now started to roll out here at the University of Vermont to expedite admissions and it reduced that ED length of stay. We also really want to hear from patients and families themselves. And so we participated in this quality project to speak with patients and caregivers about what are the things that really drive their quality of life and contribute to better outcomes and better survival. And so the green and red here show positive and negative drivers, but the shared things that we heard in these interviews are that patients and caregivers both want common goals of maintaining health and function, maintaining well-being, living in the present, and being able to live their life through cancer. So our efforts now are to look at our urban and rural patients with brain metastases and really try to come up with new quality benchmarks and paths forward for this patient population. And so the University of Vermont is leading an effort with all of these institutions you see. It takes not just a village, but many villages to really combine together to figure out how we do better rural outreach for our patients with brain tumors. And so with that, I would like to thank our multidisciplinary clinical and research team here, all of the patients who shared their time and data with us, and the philanthropic donors who supported this work. Thank you.
Thanks, Alyssa. I hope you recognize what a difference it is to have an academic medical center, an academic cancer center here in Burlington. Let's give another round of applause to all of our speakers here tonight. It's now time for the Mini Dean show, and the Mini Deans are going to take over and answer and address all your questions.
Thank you. Thank you so much, Randy. Let's give him a round of applause, please. So we're going to provide cards for you to write down questions, if you don't mind, kind of old school, and they'll be passed to us and we'll dish them out. We'll ask the presenters all to come forward, please. And we can share a microphone for you. Randy, you might assign who, unless it's obvious, who would respond to each question.
The first question is about lung cancer. Have you published your results? And the second part of this is, I know several women, non-smokers, who developed lung cancer. Would your test be able to be used with low-risk people or low-risk cancers?
So yes, the results have been published. That has laid the foundation for a lot of the work that I'm doing in my lab currently. And in regards to the second question, part of the reason why we're trying to do this completely novel screening strategy is to actually be applicable to lower risk patients. Because low-dose CT scans isn't sensitive or specific enough to detect tumors in low-risk individuals, we think we might have an advantage there. Using the pregnancy test as an output may not be viable for that, depending on the application, though.
Okay, so percentage of incidental diagnosis from incidental testing as opposed to symptomatic diagnoses. So what percentage of the time is a diagnosis from incidental testing? In what location? I mean,
A shoulder scan.
oh, I see. So we see it all the time in the ER. I can tell you that we scan people all the time in the ER for trauma or for some other finding, and we'll see it there frequently. I don't know if any of you guys want to do it for brain, Melissa. Yeah, it's common in the ER for us to pick up cancer in somebody looking for
Yeah,
something else.
whenever you do a test, there's always a potential for a false positive. It looks like there might be something there like a cancer, but it's not really a cancer, and you have to do more workup for that, just like a test might have a false negative. You see nothing, but there might actually be something there. So our tests aren't perfect. Maybe the inhaled bacteria will be more perfect. We'll have to see. And I think Dr. Thomas's scans of the brain are a little more accurate than we don't usually get too many dots in your brain, but you get them in the lungs sometimes.
I would just add that I think this is the reason cancer screening is so important, because so many cancers can be detected before they're symptomatic. And so we pick them up on tests like this, but that's how we pick them up on colonoscopies and mammograms and other such tests.
But I would say every single week in the ER, not every day, but every week in the ER, we're scanning someone for something else and we'll pick up a cancer. It's a weekly occurrence. We'll get a specialist then to help us.
Great questions. Question is, who else in the country is doing lift care type of program, and what have those results been?
So there are several different financial navigation or a few different financial navigation programs. So the program that I'm adapting Lyft was developed at the University of North Carolina. And so I'm working with the researcher who created that program to adapt Lyft into Lyft care for our population here. They've actually done a little bit of preliminary work adapting it for rural populations. But again, we have a very unique rural older population here. Another researcher in North Carolina is adapting Lyft for the AYA, which is the adolescent and young adult cancer population. So there are a few different manifestations of financial navigation out there, and they are showing results. So Lyft is evidence-based, right? Like I mentioned. So we do see that it can really reduce both objective financial hardship as well as distress in patients. And so the key is really figuring out how does that work here with the unique needs of our population, right? The unique challenges of rural, older patients and caregivers, those families. So we do see that it's working, but the real test is expanding it to caregivers and families as well.
Okay, here's the next question. It's really interesting. How are you going to market a delivery system like a nebulizer to introduce a genetically modified bacteria into people's lungs? I predict resistance, the med student says.
Yeah, so we definitely anticipate that there will be correct ways of introducing this new technology to people and talking to them about it, and incorrect ways to talk to them about it. We think that part of the issue, or one way that we're trying to make it as easy as possible, is select a bacteria that people are already very familiar with. So something that's used in yogurt or other fermented products that they're already consuming. We don't like to think about it a lot, but when you eat something, you generally breathe it in as well. And so it's part of the reason why we're fairly confident of the safety profile of some of these bacteria is because they are already being introduced into our lungs. We just want them to do something useful down there.
So this might be actually for Dr. Holcomb. Could you talk about the power of a mobile cancer unit and how it could be used in a rural area?
Well, we have a mobile cancer unit. It's for cancer screening and prevention. It's not actually like a mobile health unit where we're actually doing a lot of physical exams and other intricate testing. I think it's a really powerful tool. I think we can use this to get out to the community to make it easier for patients or potential patients to learn about cancer screening, to get appropriate referrals, just to get educated. And I think that's part of what we're doing. We're actually, again, through the generosity of some of our philanthropic donors, hiring an advanced practice provider, a nurse practitioner, who will actually go out in the van and interface with people in the community and make sure that the appropriate referrals to centers for either additional testing, or maybe they don't have a primary care provider and they need to get referred to a primary care provider so that they can get that access. So I think the mobile technology is something that we can utilize here in Vermont and Northern New York, and we want to do that moving forward.
Next, I like the way this student is thinking. The bacterial biosense lab, if successful, can it be patented and monetized?
Yes, it's a new embodiment of matter. That's a patentable thing. We've put in provisionals in the past and not moved forward with them because it's not in the final form yet, and we're kind of playing that strategically.
Any other questions?
I'm going to ask a question just because I think people may want to know. Dr. Holcomb, tell us a little bit more about NCI designation.
So NCI designation means that a cancer center meets rigorous standards for cancer research, education, community outreach, and clinical care. It'll put a center in the top 4% of cancer centers across the country. It's not an easy standard to reach. We've been working now for 5 years to get to that standard before we can actually apply for NCI, or National Cancer Institute designation. We're hopeful that we'll achieve that here. It will help us. I mean, it brings in a little bit of money. That's not the main thing. What it does is it brings us recognition, affirmation of the work that we're doing here. It will allow us to recruit the best scientists and the best clinicians to our cancer center here. So those are the things we're looking forward to.
Thank you.
This is a really great question. It's for all the panelists. If each of you could remove one barrier that is currently slowing meaningful progress in cancer care, what would it be? It's an extra credit question.
Can you repeat the question?
Yeah. What barrier would you remove to improve cancer care?
Transportation.
Yeah.
That's what I would remove. I would give access to everybody to transportation.
I think my answer is going to be pretty obvious. The financial barriers that people face that sometimes make people even afraid to find out if they have cancer, right? And really get the knowledge that they need to get the treatment they need. So yeah, some of those financial barriers, which are especially bad for our rural communities. So.
I think we need more support for early stage research. I think a lot of crazy ideas have become reality in cancer care, especially over the last decade, and that's accelerating. But we need to support projects when they're at their most vulnerable early on.
I'm going to extend that to then translating that research to patients being able to access it, because I think there are a lot of cancers out there for which either we don't have a cure or the treatments we have a lot of toxicity. And so really continuing to advance that pathway from discovery to patients so that we can move our treatments forward, I think is critical.
So I'm not one of the panelists, but I'm standing here next to them. So I'll add something in. But I think we need to reinvent our rural workforce, our physician and nurse practitioner workforce that we have that helps support our rural communities. We know it's really difficult to maintain a practice in a rural community from a financial standpoint, the way healthcare is reimbursed in this country. And so we need to not just have little fixes and throw a little money in here and there. We need to really reimagine how we do that and how we use the resources that are available at a center like ours to reach out into the community to solve those workforce problems.
Hear, hear. We didn't discuss colon cancer specifically, but can anyone talk about the Cologuard home colon cancer screening test? Is it effective? Is it equal or close to a colonoscopy? Anyone?
Yes and no. So colon cancer screening has lots of options. That's the good thing, right? You can do a FIT test, that's testing for blood in the stool, which you have to do yearly. That's a pretty good test. It's pretty inexpensive. It's relatively easy to do at home. Cologuard is testing for blood in the stool, but also testing for genetic abnormalities that are found in cancers. It's good for detecting cancer. You have to do it every 2 years, but it's not very good for detecting precancerous lesions, the polyps that occur in the colon. A colonoscopy, much more difficult test, requires a prep. I can tell you that someone who's driving 4 hours from a rural township that has to have a colonoscopy that next morning does not want to do the prep all overnight and then drive 4 hours here. So it's a much more difficult test, especially for our rural communities. But it has the advantage that it's not only a diagnostic test, but also a therapeutic test, because precancerous lesions can be taken out during the colonoscopy, and then those won't grow into a cancer sometime later. That has to be repeated usually every 10 years. So maybe 5 years if you have a bunch of polyps. So all of those are good screening tests, and really the message is a screening test is better than no screening test.
Thank you so much. Thank you to all of our speakers. Really wonderful evening. Now, as has been mentioned, we could not do the work we do here at UVM Health, at the College of Nursing and Health Sciences, the College of Medicine, without the support of those around us through philanthropy. As you may know, we work closely with the UVM Foundation to develop the mini-med program. And just speaking as one of the 3 original mini deans now with Noma, I don't know who can possibly fill your shoes. We've enjoyed a great partnership with Ginger Lovkowitz, who is in charge of academic health sciences, and in terms of philanthropic support and really overall support to this program and our colleges and the health system. So let's give her a warm round of applause, and thank you, Ginger.
This? Okay. There we go, much better. But tonight, I'm breaking that tradition. And as Randy has alluded to, I do actually have a pop quiz for you to review and to underscore what we've heard from our amazing presenters tonight, and to reinforce, as you've heard, what helps make it possible. So the question is, which of these outstanding programs was funded by philanthropy? The answer, of course, is absolutely all of them. In fact, some of these programs are 100% funded by philanthropy. They would not be in place but for the support of our community. As you've heard tonight, in our rural area, cancer care is not just a medical challenge, it's a complex and logistical challenge as well, exacerbating an already very heavy financial and emotional burden. And yet, time and again, when gaps are identified, people step forward. Clinicians, caregivers, families, and neighbors go above and beyond. Scientists and clinician scientists pursue new discoveries with urgency, brilliance, and determination, thankfully. And our community comes together to help each other and to advance knowledge. Philanthropy is often what drives meaningful progress and meaningful support for our patients and their caregivers. These efforts do not happen automatically. They happen because individuals decide that healthcare, the health of others, matters enough to invest in it. So as you reflect on what you've heard here tonight, I invite you to consider your role in that story as someone who can help close the distance, literally or figuratively, between a patient and the care and support they need and deserve. Every donation to our Cancer Center programs and research becomes part of a larger effort to improve patient experiences and outcomes. So thank you for being here tonight. Thank you for your interest, and thank you for your support. And we can now adjourn to our reception, where hopefully we can continue the good conversation. Our presenters will be present. So excellent. Thank you.